Thank you for watching the World Community Magazine's Hour of Power Live on Facebook with your host Edward McQueen and April Garner Davis.
Good evening. Good evening to you. We want to welcome you to our program this evening. I'm Ed McQueen, your host, and this evening, we're talking about it's almost familiar right now, but it's getting to be better than before, the topic of prostate cancer. And we have with us a person of expertise that we think you all are going to be pleased with to hear what he has to say, and I'm certainly anxious about it. So we're going to get right into it, but before, just to let you know that my co-host April is working diligently behind the scenes, and just want to make sure that everything is running straightforward this evening. Okay, so without any further ado, I want to introduce, because the topic itself is very broad, but it's becoming very narrow now with the new advances and techniques and technology for which to deal with prostate cancer. So I've got a lot of on-street conversations today and yesterday. People asking questions and they wanted to, they said that they were going to be listening in. They may not call or type in or send comments, but they're going to be listening because it's becoming a huge topic and it's becoming a very, very critical topic, especially in the underserved neighborhoods, so to speak, people who are not getting information for which to deal with this issue on prostate cancer. So without further ado, I want to introduce you to Dr. Curtiland Deville. Is the medical doctor, and Dr. Deville is the clinical director of radiation oncology and the co-director of the prostate cancer multidisciplinary clinic at Johns Hopkins University, Johns Hopkins Kimmel Center, and that is located at the Sibley Memorial Hospital. Okay. And that location is what we're going to talk about later on is where the new advancements in the new radiation therapy was chosen by Johns Hopkins. That is the proton therapy for there. And Dr. Deville is also an associate professor of the Department of Radiation Oncology and Molecular Radiation Sciences at Johns Hopkins University School of Medicine, as well as the Department of Oncology. He's the board certified in radiation oncology by the American Board of Radiology. So I can go on and on and on, but it has to take up a lot of time. And I know there's a lot to be said about what you're going to be sharing with us, Doc. So if there's any more that you want to say about yourself, feel free. So, yes, sir.
All right. Well, thanks so much for having me. I think it's a wonderful opportunity to be able to meet individuals and folks, outside of the clinic and meet them before they present to us in the clinic potentially for some of these issues. So I'm glad to be able to join you guys this evening and talk about prostate cancer and the importance of screening for cancers in general. I can tell you a little bit about myself and my background, just, maybe to kind of kick it off. Because I think it's relevant to the conversation. I didn't grow up with like physicians in my family, or I sort of knew I wanted to be a doctor, but I didn't even know what specialty. I went through my rotations and was really drawn to cancer patients. So decided on oncology. And when I started learning about, because really every division, every specialty in medicine has an oncology, has a cancer branch, because really any part of the body, any cell in the body can become a cancer. But I got interested in radiation with the technology, with the treatment design, with the planning and the things that we can potentially talk about. And so I did my training in radiation oncology at the University of Penn in Philadelphia. And there is where I started to see a lot of Black men with prostate cancer being in Philadelphia and West Philadelphia. And we also covered the veterans, the VA hospital. And so it started to strike me, I started to become curious about why are Black men more likely to be. I started to learn, the statistics around Black men having a higher incidence of prostate cancer, being more likely to be diagnosed with it. But the more alarming statistic that they're twice as likely to die of prostate cancer. And most of that we know now has to do with access to care, insurance, different things like that we call social determinants of health. And that really, when you get high quality care, your outcomes are just as good. So even though we're more likely to get it, doesn't mean that we have to be more likely to succumb of it if we actually get the appropriate treatment and management. So that's what's led me to this point in the importance of being able to talk to timely, high quality care.
Right. So we'll just go back and forth. When you notice in Philly, but a number, you said, number of Black men who had prostate cancer, at what stages were more prevalent? Did they come in the late stages and then looking for miracles, or early stages after getting a checkup indicating that their PSA has moved, or is rapidly accelerating or something like that?
Yeah, I mean, we see all of that. I think if we're talking about like healthcare disparities in prostate cancer, cancer disparities in general, Black men, stage for stage, are more likely to be diagnosed with more advanced disease when it's picked up. So they're going to be, is it localized, or is it confined, or has it spread beyond the prostate? So those are all risks. But even stage for stage, the outcomes can be worse. So it's not just about getting the screening and getting in to see a physician and having appropriate testing done. But it's also making sure that when you do get a diagnosis that you're, following up, that everything attention is sort of not being ignored. There's not being delays. There's not being things that are going to end up to us leading to have worse outcomes. But I think, the key first step is engaging with healthcare and the healthcare system, undergoing physical exams, because the reality is nowadays in the United States, in general, we detect prostate cancer much earlier because we have a screening test, which is basically the simple blood test, the PSA, prostate specific antigen, which is basically a little protein on the prostate cell. It's something that we can measure in the bloodstream. And if that number is going up, then we can have a suspicion, or it may be worth pursuing further workup, specifically a biopsy, something, searching for cancer within the prostate, because of those risks. So really, in general, nowadays, men are not presenting with symptoms from prostate cancer. We usually we're sort of staying ahead of it. We're catching it before there's actually symptoms or problems. If the person is being seen appropriately, going in for their annual physical,
right,
and having a conversation with their primary care doctor about the benefits of screening.
So, talk a little bit about the differences of treatment. I know your specialty is the radiation part, but my conversation deal with some people who I've done a lot of conversation. People who have had complete surgery or prostatectomies, and in a couple of cases, there's a recurrence of the prostate cancer. Can you talk a little bit about that?
So, once we diagnose or figure out there's a cancer, we have to kind of classify it. Sometimes we call that staging, figuring out where is it located, is it confined, is it all within the prostate, is it all within the pelvic area, even if there's some like regional spread to, let's say, lymph nodes or something close by, or is there distant spread, something that, for prostate cancer, it likes to go to the bone.
Right.
So those things will influence the types of treatments that are appropriate. If it is spread distantly to the bone, we call that, metastasis or metastatic disease.
Right.
Those patients will usually be treated with what we call systemic therapies. They'll see a medical oncologist who will use things a lot of time, mostly the time for prostate cancer, they'll be hormone or anti-hormone based, because prostate cancer responds to a suppression or sort of removing testosterone, which is sort of a fuel for the cancer. But that's, a smaller percentage of men are actually diagnosed with spread of cancer. The majority of men are diagnosed where it's still localized, or we think it's still localized to the prostate. And so they can potentially undergo curative treatments, treatment with the intention to cure or eliminate the cancers. The wide majority of men who are diagnosed in the US, that's the scenario we're in. So when they're in that scenario, we still have to do our classification, which we call a risk group stratification. And we classify the cancer into these kind of categories or buckets of, how aggressive is the cancer? Is it low risk? Is it intermediate risk or high risk? And that is, what is the risk of the cancer progressing or really recurring, coming back after its first treatment? And so that will also determine the treatments that are available. But in principle, whether they're in any of those categories, their treatment options are generally going to be either surgery based or radiation based. So I tell patients you can take a surgery road or you can take the radiation road.
Right.
We know that in general, their outcomes are going to be equal no matter which road which they take, whether it's surgery or radiation. There are different things that influence which way a patient may go. One major thing is age. It's the ability to kind of tolerate a surgery, the risks related to surgery. So generally, you'll have younger patients who can tolerate surgery, have surgery. So I might tell a patient that, most patients under 60 are steered towards surgery, over 70 are steered towards radiation, and 60 to 70 go either way, depending on their overall health status, their personal preferences, their other medical problems, those sorts of things. And so very often we may end up, I'll tell the patient, we might end up with a menu of options that you have to eliminate the cancer for treatment. We're not going to end the conversation saying this one is better for you. It's really guiding that patient using what we call kind of a shared decision-making approach to figure out, does it sound like surgery is a better option for you in terms of what I'm hearing, or does it sound like radiation might be an option? Now, sometimes it's very clear there are things that steer us away from one or the other. The surgeon might say, oh, this patient has these other medical problems. There's a lot of operative risks, the bleeding disorder, wound healing, prior abdominal surgeries with scar tissue. They may have things that kind of lead them away from surgery towards radiation. The opposite may happen. They may have, there are some rare, risks, things like inflammatory bowel disease, Crohn's, ulcerative colitis, that steer us away from radiation towards surgery. So it's really, when I'm sitting in a consultation with the patient, going through the features of their cancer, we're also looking at these other parameters to try to make a decision around, which is going to be a better option. But there's a ton more in terms of types of surgery, types of radiation that, we'll really drill down into so that they kind of fully understand what all those treatment options are and what do they look like, how long do they take, what's recovery look like, what are the side effects, what are the risks, those sorts of things.
Okay. I know you don't deal with the prostatectomy side. You deal with the radiation. But I have, and maybe the audience will also, the part about hormone treatment. When does that come into play? When is that needed before, or after, or during a person's interest in treating prostate cancer?
Prostate cancer, yeah. So there's a couple of scenarios where we use hormonal therapy, commonly. Generally, if the patient's going to have surgery, there's not much evidence that it's helpful to have hormonal therapy before the surgery, and sort of preparation for. There's been various studies done, and there are some studies that continue to study and assess that. So it's on a clinical trial or something like that, a person might be offered a study like that. But in general, hormones are going to be used in two settings. One is that one I talked about before, where the patient has spread a cancer, they're seeing a medical oncologist, and actually hormonal therapy acts very quickly. And really the correct term, we're sort of not supposed to say hormonal therapy, we're supposed to say like androgen deprivation or androgen suppression, because we're not giving the patient hormones. It's kind of what I said before, anti-hormones. We're giving them usually a pill or an injection that tells the body to stop producing testosterone, the male hormone testosterone, because prostate cancer is feeding and fueling off of testosterone. So if you have aggressive cancer and you remove testosterone immediately, it's going to act to slow down and halt the cancer progression, delay the spread, those sorts of things. We use it with radiation because just as studies were done with surgery and didn't find a benefit in improving surgical outcomes, studies did show benefit in improving radiation outcomes in some settings. So men who have more aggressive features, if they fall into that high risk group, that usually is associated with something like a high PSA value. So that blood test I mentioned before, if it's above 15 or 20, getting into those higher values and the person's coming for radiation, we're probably going to recommend some hormonal therapy, temporary suppression of their testosterone. If it's more aggressive, so we haven't talked about the biopsies yet, but if you do a biopsy, we're going to score it. We're going to give it that Gleason score, which is with how the pathologists score it. And that's a sense that gives us a measure of the aggressiveness and the risk of spread. So we kind of choose the amount of hormonal therapy based on that Gleason score. If someone's Gleason score is 8 to 10, that's the high, we call it high risk. Those guys, we might give them up to 2 years of hormonal therapy, of testosterone suppression, compared to someone who, say, has a Gleason 7, we may use something like 4 or 6 months of testosterone suppression. So that's
when do you stop using? When is it best that you stop getting hormone therapy?
Yeah, so the guys who are metastatic and it's spread throughout the body, they get it forever. Actually, they get it forever if it's metastatic.
Is just that effective? Is that effective that it suppresses the cancer cell, so to speak?
The problem is certain cancer cells can figure out a way to sort of work around. So patients who are metastatic, it may work for like 3 to 5 years, or sort of 3 years, and then it's starting some of the cells. So the way I was sort of taught, the medical oncologist taught, is it's sort of always working for some cells. The problem is cancer cells are sort of continuously mutating. They're just trying to divide uncontrollably and spread. And so you have some that figure out a workaround. So you always keep it on board for the patient with metastatic disease. They stay it on forever. And then they'll add additional therapies on top of it for the cells that aren't responding, in principle. But for radiation, we usually use a prescribed course. So we say, this guy has, what we call kind of an unfavorable but intermediate risk cancer. So he's Gleason 7, 4 + 3 was the score. That's someone who we may just use 4 months. So we tell them, okay, you might get, say, 5 weeks of radiation and 4 months of hormonal therapy, basically a pill you take once a day for 4 months, or an injection. You can even just give like a one-time single injection that's going to last for 4 months. And so the hormonal therapy is working. The suppression really of the blockade is really what we call it. It's blocking the signal to make testosterone, is working for that period of time. Then when they stop that pill, gradually, so you remove that blockade and the cells are going to start to, the normal cells are going to start to make testosterone again, and the patient's testosterone recovers. Yeah.
Okay. Yeah. So what about the magnitude of the, when it's metastasized? If it's, are there certain stages that you can't, that hormone therapy won't do any good?
That's not necessarily the case. Really it's always treatable, right? Generally, when we're talking about sort of for prostate cancer, we may, there's a key piece here where, if it's metastatic and spread through the body, the patient's put on hormonal therapy. They're on that for a while. And we monitor that through the PSA. So usually their PSA blood test goes down. It might be what we say undetectable. It's so low you can't measure it. It might be something like less than 0.1 is the way the lab reports it. But then suddenly maybe it's 2 years down the road and they're still getting those injections every 3 months or every 4 months, but their PSA starts to rise. That tells us that some of the cells are starting to work around. And we specifically call that castration resistant. So you can be castration sensitive or castration resistant. Or sometimes people say hormone sensitive, hormone resistant. So when that castration resistance is starting to come on board and those cells are mutating and working around, that's when the medical oncologist is going to start adding additional types of hormonal therapy on top of what they're getting. And they usually go in kind of very sequentially, or sometimes they might have started with even 2 drugs at once, and they might, so stop one, start another one. But it's also where they start to think about other types of treatment, like chemotherapy. Chemotherapy is not used as often for prostate cancer as it is for other cancers, but it can be used if there's a lot of spread, or if there's involvement of other organs. So I mentioned prostate cancer likes to go to the bone or the lymph node, usually before it goes anywhere else. But if it spreads like to the lung or the liver or some other areas, then usually they go to chemotherapy right away. And there's some other types of treatment. There's something, sometimes people refer to as liquid radiation or radiopharmaceutical therapy, which we've started to do now, and our nuclear medicine colleagues do as well, that folks may have heard of, Xofigo, Victo. And those are using radiation in a form that is actually traveling through the whole body instead of just targeting a particular spot. So there are a variety of treatments. There's some immunotherapies, targeted therapies that are being, added or studied for prostate cancer. So we really are over time, just kind of as you said in the intro, year by year, we almost yearly, we have at least one new treatment that is prolonging survival in men with metastatic prostate cancer and helping them live longer.
Right. That's interesting. As recent as today, I was at someone's office and we were talking about the broadcast that was coming up in the topic of prostate cancer. And this particular person had, he explained to me that he's been taking some kind of medical medicine for the past 15 years because of, he's 71, by the way, taking that for the past 15 years due to enlargement of the prostate. And that caused his PSA. He said he had a PSA of 11 or 12. That's critical, really? When you, but he said that he had a biopsy and the biopsy was negative.
Yeah. So it sounds like what you're describing. So this is a known issue with. Just to kind of walk back.
Right.
Go sort of earlier, more common, much more common than prostate cancer in men is just what we call
BHP, right?
BPH, benign.
BPH, yeah.
I've heard it's just benign enlargement of the prostate. So the prostate just kind of increases in size over time. There's kind of two parts to the prostate. There's a central part. So the prostate is about the size of a walnut, sits at the floor of your pelvis. The bladder's on top of it. The urethra is a tube. If you think of it, this is how the urologist taught me, the pelvis like a funnel. So your bladder is there, that, the funnel, the prostate sitting at the bottom of it, and the urethra, the tube that drains the bladder, runs right through the prostate, right? And then goes out the penis, right? And so that's how we urinate. So the problem is that all that anatomy where the prostate is just surrounding that urethra. When it increases in size over time, particularly that central portion, because cancer is actually usually in the periphery. The central portion is usually the benign part that's increased. It actually starts to block the urethra, and then you can't empty well, you're peeing often, you get more urgency. These are sort of the classic symptoms of BPH that men, have that we have increasing with age. So there's kind of two main treatments for that. Medication-wise, there's one medication that can help to relax the prostate, relax the urethra, help you get a better emptying. And the other medication is one that can actually just shrink the prostate down.
Right.
And that's called finasteride or dutasteride. And so, it's common for men to be on that. The issue with that medication is that we know it shrinks the prostate. It also lowers the PSA. It kind of cuts the PSA in half, more than half. So if somebody is taking that medication and they're getting their PSA checked, you're actually supposed to double your PSA to 2.5, multiply by 2.5. So if you have a 4, that's actually a 10 in PSA value. But the problem is if folks aren't paying attention or aware of that, they may be just monitoring, this PSA and not realizing that someone actually has a high PSA value because it looks very low. And so we see, many men that were sort of diagnosed that way. Or as you're mentioning, in this gentleman may have been actually referred for a biopsy, had it, but it didn't pick up the cancer. And that's a whole nother conversation that it's an important conversation to have, because I hear that all the time. They say, well, I had a biopsy, may have had 2 or 3 biopsies, and it didn't show the cancer. I told I was fine, it was benign. We see the report. But it's not always, it still says that the biopsy didn't pick it up doesn't mean there's not cancer. Because what the biopsy really is, if you have your prostate, again, we talk about just sitting at the floor of the pelvis. Historically, what the urologist did was kind of like a blind biopsy. It's we call it systematic, 12-core sextant biopsy. So they're getting an ultrasound. They're using an ultrasound guidance. They put that probe in the rectum, and then they insert needles. Actually, the probe has a needle. It can go right through the rectum, or they can go through the skin of the perineum, the space just behind your scrotum. Like if you sit on a saddle or on a bike seat, right there is where, if you stuck a needle right there, that's where your prostate is, right? So they can stick needles through the skin there and remove prostate tissue. So they would just systematically sample the prostate in sort of 12 different areas and look under the microscope and say, is there cancer? Well, now we've kind of evolved where MRIs, so right, MRI imaging was developed for prostate cancer. And I say kind of very fancy, dedicated, zoomed in, with special sequences, looking at really teasing out the cells and trying to identify areas of tumor within the prostate. Because this is different than, say, something like lung cancer or breast cancer, where you have a big area. So you have in lung cancer and brain cancer, you have a big tumor that's sitting there. That's how it came to attention. With prostate cancer, it's just a blood test usually. So you don't know where's that cancer. So we're sort of exploring the prostate. So now MRI has helped us identify the suspicious areas within the prostate, so that we're not just doing sort of a blind kind of biopsy. So now what's often done, and there's studies have been done that show that this actually improves the outcome. You're more likely to detect that cancer, not miss the cancer, and essentially is what was happening. So that you do the MRI, it might pick out, a couple of spots. Usually they do sort of up to 3 suspicious areas. Then when they go and do the biopsy, they're doing what we call a targeted biopsy. So they're or an MRI fusion biopsy, those are the sort of terms they use. So they take the MRI, fuse it to the ultrasound, and in real time, as they're doing the biopsy, they're going to guide that needle right to where they see that suspicious tumor in the prostate, and they're going to sample that area. They're also going to still do that systematic sampling of the other areas, because prostate cancer can be multifocal. You can see it in multiple areas. And then we look under the microscope and see it. So in that way, you're more likely to detect the cancer. So I often, if I'm seeing patients or someone mentions that, we'll kind of ask, did you have a targeted biopsy? Did you have an MRI? Many patients I see may have not had an MRI as part of their workup. And so those are the things that help us have reassurance if cancer is not picked up, that, we're really testing and making sure. Or even when cancer is picked up, are you picking up the most aggressive cancer? Because when we design our treatment plan, we're going to do it based off of that score. What was the most aggressive cancer detected? And sometimes you might do imaging after the biopsy and see, oh, there's something more aggressive in a different area that probably was not sampled or was undersampled. So there are some nuances there to therapy to really understand, to making sure that you're, working up, but also diagnosing the most aggressive cancer.
Okay, thank you very much for that. Just talk a little bit about the different therapies with the radiation. My research shows that there are 2 main ones. There's photon, PHOTON, and the other one is proton, which is the more targeted one, I guess, or that's the latest one, right?
Yeah. So I can even take a step back from there. So there's internal, usually when I'm kind of going through it, there's internal and there's external radiation. So the internal, sometimes people have heard of the seeds,
Right.
It's called brachytherapy or brachytherapy.
Right, yeah.
Where we're implanting radioactive seeds into the prostate, kind of how the biopsy was done, how I explained that procedure. But this time, rather than snipping, you're sort of placing radioactive seeds that cover the prostate, kill the cancer. So that's a standard therapy. There are, it's been done for a long time. There are specific criteria when we select patients, just to make sure we're minimizing the risk, because it is an invasive procedure. So we don't like to do it in patients that have very large prostates or a lot of urinary symptoms from BPH, because they may have more side effects, more swelling, and there's a prolonged catheter risk or things like that. It can also be done with, instead of seeds, nowadays it can be done with catheters. So that's still called brachytherapy, but instead of the seeds are called low dose rate or LDR brachytherapy, that's called HDR brachytherapy, high dose rate brachytherapy. So sometimes folks may have heard, I see patients, they say, oh, my friend had the seeds, what's that about? Or my friend had this catheter, treatment, what's that about? So those are just alternative options. The catheters, it's a little bit sort of newer, or there's a shift towards doing that more, where the same type of procedures done, you guide a needle into the prostate, but rather than depositing seeds, you have a catheter there and you bring a radiation source into that, you expose the prostate to radiation, and then you take that catheter out. And that way you're not implanting radiation in the body. The patient doesn't leave radioactive with, restrictions and all these things that they have to do from a radiation safety standpoint. The issue is that sometimes if they have more aggressive disease, we don't do those procedures by themselves. They still have to be done in combination with the external radiation. So the patient may have something like 5 weeks of external radiation that we'll talk about, and then they have a seed implant, and then they have the HDR boost or catheter treatment. So there's a variety of treatments and that are available. But the most common treatments that men get for prostate cancer in this setting is the external radiation. And within the external radiation, there's two categories. There's the photon, as you mentioned, or the proton. And most commonly, most men in the country are going to get photon. The most modern form is what we call IMRT, intensity modulated radiation therapy. And that's just because there's, thousands of linear accelerators that deliver that across the country. There's only 40 some, 40 plus proton centers in the US right now. So a small percentage of men are actually getting proton therapy for their prostate cancer. They've not been compared they're delivered very similarly. So it's the same length, duration of treatment. We can do it in 8 weeks. We can do it in 5.5 weeks. We can do it in 4 weeks. And the fastest course we can even do is in 5 treatments every other day. That's called stereotactic body radiation, where the way I describe this patient, you're getting a really high dose. You're getting like a week's worth of treatment in a single treatment. So sort of much harder hit to the prostate that lets you get through faster. But that's been shown to be safe and effective, again, in well-selected men who don't have a lot of, other medical issues, very large prostate, urinary problems, bowel problems, or things like that, that you might be able to get away with doing that. But most commonly nowadays, in fact, the most common regimen in the US is usually something like 28 treatments. And I say the Europeans and the Canadians did it a little faster. It was like 20 treatments when they were designing their accelerated regimen. So those are about the two most common if you're getting it in 28 or 20, so 5.5 or 4 weeks of treatment. But back to that photon-proton conversation. So photons are X-rays, and they enter and exit the body. So when they enter and exit beyond the process, so you kind of hit the target and you pass through it, there's some dose exposure. You're exposing the surrounding tissues to radiation. It's sort of a low dose bath or low dose spray of radiation. With protons, there's no exit dose. So when we deliver the radiation, it hits the target, the beam stops, and you can reduce or eliminate, much of that low dose bath. So we can better spare and protect the adjacent areas. The key is that no one's yet proven that protons have less side effects than the photon, than the traditional X-ray radiation. There was 2 big national trials that finished, somewhere around 2022, or sort of late 2022, early 2023. So we're waiting for the more long-term outcomes for that data to come out and to be reported to tell us whether in a head-to-head fashion there was any difference in the 2 treatments. We know from a cancer standpoint, both of them are equally effective at eliminating the cancer. As I tell patients, you hit the target, whether you hit the target, you hit the prostate with photons or protons, you get the same dose there, you're going to eliminate the cancer in the same way. The question is, because you have less dose going to the surrounding tissues, can that improve the side effects? Or one of the bigger risks, which is rare, is the risk of creating a new cancer from radiation treatment, or what we call a secondary cancer or secondary malignancy. And really, that can be at any cell in the body, because radiation is traveling through everything to get there: the skin, the muscle, the bone, the bladder, the rectum. And those, if they manifest, if they come about, usually takes, at earliest about 5 years, some maybe like 10 years down the road. And so there are some studies that suggest that that low dose bath, by reducing that low dose bath, you may reduce the risk of creating a new cancer down the road. So that's all the data we're kind of waiting for. We're in the era where these studies were done. We're waiting for the outcomes. And so we don't officially know. So very often in the US, I tell a patient, when the jury is still out, we don't quite know, but it's often their insurance that's going to decide in the US whether they actually cover the proton therapy. And so there are some insurers who fall on the favorable side, who might say, while we're waiting for the data, we'll cover the treatment, or we'll cover it on a clinical trial. So many institutions have clinical studies or registries like we have, where we're continuously studying the development, the delivery of the treatment. Or others that just say we won't cover until we see, until those results are out to really know. So we feel very comfortable ultimately using both. I'm seeing a patient at our center, we have both treatments. And frankly, if one is not covered, if the proton is not covered, generally we can just go ahead and treat them with the photon therapy. If we were, they wanted the proton, or if we were attempting to use that, we can always defer to the photon therapy.
Okay, so have there been any drastic cases in the past, or shall I say historically, about the regular photon rays or therapy being used as opposed to proton introduction?
Well, so I thought you were going to ask if there's any studies that have shown like a what benefit. Like, so there are areas that we see a benefit to proton therapy. That studies that have come out. One major area is pediatrics. So on the one hand, it may be considered sort of almost even unethical to randomize a kid to getting, more radiation dose exposure than, so protons are sort of a number one indication for using proton therapies for pediatrics. And there have been studies that have shown a benefit, for example, treating, brain tumors in kids. The low those low doses that I talk about do make a difference in terms of cognitive function and IQ and those sorts of things. So brain tumors in adults even is another, common indication of benefit. Another area, the best areas, a lot of data coming out more recently is in the head and neck, and also like the esophagus. So, with swallowing, with eating, because there are also those low doses, impact things like taste and swallowing and function, and the treatments can be really tough. They may be giving therapy with the radiation, and so reducing the low doses of radiation. So those are some areas where protons have shown and are showing, very promising. In fact, the guidelines that are produced by our national body, they're technically not guidelines. It's called the ASTRO model policy. So they are sort of guidance to inform insurer payers based on the available evidence. So there was sort of one initial guidance policy statement in 2017, was recently updated in 2022, sort of early 2023. And they updated, there was a sort of whole list of diagnosis and disease sites where they updated based on now having more evidence of benefit. It includes a lot of those things I'm talking about, like esophageal cancer and certain head and neck cancers. Also I talk about pediatrics, usually we sort of define that up to age 21. But there's a whole category of, what we call AYA, adolescents and young adults, right, who sort of that age from like 21 to 40 or 21 to 39. Where because of the risk of secondary cancers, we want to be able to, try to use proton therapy often in those settings. And, patients are being diagnosed now at younger and younger ages with some of these cancers. And so there may be benefits, things like, for example, what I treat mostly prostate cancer, but do treat other urologic cancers. So testicular cancer, seminoma, is somewhat rare, but it's a cancer of young adult men. And if they do have, one of the risks that they can have is spread of cancer to the lymph node regions. And so we give them radiation. And there, especially in very young patients, you can reduce that low dose spray going to all of those very sensitive organs, the kidneys, the bowel. And so those may be, kind of other areas where we'll see benefit. But really, we're in the era of studying and really trying to learn where can we maximize the benefit. Where are areas where we may not see that much difference, and be fine to get either or just to get traditional radiation, and where are others where we do see greater benefit and we can kind of lean into and really focus on those.
So, would you like to get into? I don't know if you convey this to your prospective patients in counseling or whatever, but costs.
Yeah.
Could we say that if you don't have insurance, that is cost prohibitive to, for lack of a better word, for the proton treatment as opposed to the photon treatment?
If someone doesn't have insurance, any even the modern photon radiation is going to be a pretty hefty cost. We work, certainly there are scenarios, I don't mean to make light of that, of not having insurance in the US. If someone has a cancer diagnosis, very often we have a whole team, social workers, case managers, folks that will try to help that individual to get, even if it's like Medicaid or, something, to figure out like what they're eligible for. I think now what you just said needs to be broadcasted more. To let people know that there's help out there. There's assistance in getting the type of treatment that they need for prostate cancer. Because a lot of time that's to them that implies that they might as well not do anything, or they'll just pray that it goes away or something like that. You're right.
Simply because they don't have the initial funds for that.
Exactly. No, I hear you. And I'd be very concerned about that too, right? I think that's the barriers to even doing basic things like a physical exam, right? The person might not have insurance, and then they're not getting just the basic screenings, and they may, and we're telling, if you have symptoms or you feel, get it checked out, and they're delaying and not seeing because they don't have insurance or they're underinsured, right? This idea you have insurance, but everything is still so costly within the tests and the exams and the things that you have to do that it becomes sort of prohibitive. But I would agree with what you said before, to always speak up. And we have resources, very often, unless the person says something, they may not, be referred to social worker or other types of programs. And ultimately, even like philanthropy, the donations, we have charity care, we have different things that can help people that we see, very compelling cases, very appropriate for treatment. And we really want to try to do everything that we can to help them if they don't have insurance or are underinsured or in a sort of that scenario, that kind of way. Yeah.
Well, on our comment section, if you can see there, where there's a gentleman that's very, very knowledgeable about the photon treatment, and he's conversing with us by way of his comments.
Yeah.
And one there is saying that the federally funded clinics are available for all individuals with insurance or no insurance, with a sliding scale fee for access to care throughout the nation.
Yeah.
Of course, he's a veteran.
Yes.
Yeah.
Yeah.
That might have something to do with it.
Yeah. No, I mean, I think the point is well taken that, if you're in a scenario where you are worried, seek out resources. There are a ton of patient advocacy groups, the American Cancer Society. There are a variety, whether you're presenting to a clinic or a hospital, an institution, mostly by the time you make it to the cancer center, we're going to be talking about these resources. But really, we want people to be, your best outcomes are going to be when you're kind of staying ahead and you're in a preventive maintenance, right? You're undergoing healthcare, right? Like, on a regular cycle, you're doing your annual physicals and not sort of waiting until you have a problem. So really, it is important very early on to be doing those things for all types of cancers.
So, and this gentleman, his name is Lee Moultrie, by the way. He's from Charleston, and he's still conversing on the side. Usually we would put it up on the screen, but well, there it is. Yeah.
Yeah.
They said for you to know that he was treated with a proton, also in Jacksonville, Florida.
Yes.
That's the originator, I believe, down there in Florida.
Good colleagues down in Florida. Well, actually, the first hospital-based facilities were Loma Linda in California. So they've done, a lot of prostate cancer history. And then Mass General, hospital, part of Harvard and in Boston. But Florida was one of the early. They may have been when I was at University of Penn is where I did my training. We were the 6th academic center that opened back in 2010. Florida opened just before that, so they probably were like the 4th or 5th center. So and Florida did. I mentioned there was 2 national trials. One was led by the Harvard group, Mass General group, and for prostate cancer, comparing proton and photon. The other was led by Florida. We had that one open at Johns Hopkins, part of that study team with the leadership there at Florida. So they do have a strong history of treating prostate cancer with proton therapy. Yeah.
Okay. Well, I guess we've gone over the cost a little bit. So, a couple of things before we go there. The old adage, or the common saying today, is that you don't have to die from prostate cancer.
Yeah.
Does that still, in general, apply? Is that still 100% true?
I think that's our fundamental goal with all of this, right? I think because you do hear, I hear the men coming in, you do hear things like prostate cancer is not that aggressive, or I hear that all men are going to have it. The problem is I kind of have to tell, our job, our goal is to tease out who does have the aggressive prostate cancer that can kill, who does have potentially lethal prostate cancer, versus who has a prostate cancer that's not going to do that, or that you can manage well. And essentially kind of what I was talking about before, where you're going to manage it essentially like a chronic disease now, where I tell the person it's like high blood pressure, diabetes. you may have a pill or an injection you're taking, but it's essentially going to be controlled. And so that, yes, the person may die of something else. That's ultimately our goal as a prostate cancer oncologist, is that we control and contain, even if it isn't a scenario where it's spread and it's not curable, that we can control it as long as possible and actually help to maintain high quality of life and function, right? We don't want pain. Don't want discomfort. We want people active and living their daily lives. And many of the treatments can allow that. But, if someone is diagnosed with metastatic prostate cancer, so stage 4, the survival at 5 years is only like 25 to 30% of men. So a large chunk of those men are going to die from prostate cancer. Right. And so we want to be picking it up early. That's why you're pressing so much on the need to check, to have a conversation with your primary care doctors, to know whether you're being screened for prostate cancer. Because that's what often I hear when I see men, will sort of ask, was the PSA being checked? Were you being screened for prostate cancer? And they'll say things like, well, I don't know. I think it was. I don't know. I always say, if you don't know if you're being screened for prostate cancer, then you're not being screened appropriately. Because actually the guidance is not just to do a PSA blood test. The actual recommendation is to have a conversation with your provider, whether it's, primary care doctor, urologist, whoever it is, about the risks and benefits. So they have to understand your family history, your risk factors, right? They have to talk to you about, if we do have a high value, do you want to pursue a biopsy or not? What are the risks of that? So it's a lot. I know primary care doctors, everybody is busy and has a lot on their plate, when you're seeing a patient and you're going through all those things. But for prostate cancer specifically, it requires having that conversation to really understand, whether that screening should be pursued. And so I know that men, there's sort of a stigma talking about prostate and talking about, the anatomy down in the pelvic area. They shy away from it.
Yeah. So especially if they're of middle age or so forth, or young. Where they think that the side effects shouldn't be hitting them right now, or something like that. Exactly. Explain a little bit about the screening. What is that? Does that encompass?
Yeah. So usually it's going to start with a primary care doctor, and it begins. The current guidelines say by age 50 for normal or average risk, that you should undergo those. So one, it's that conversation I meant. Talk about doing it. So they shouldn't just be ordering it and you don't know what's being ordered, right? It should be on a screen for prostate cancer. Do you want to know about? Let's talk about the risk of it. Do you have a family history of it? Do you have any certain risk factors? The average age of diagnosis is 65. It's the sort of 60s, but we start at age 50. Now, anyone with a higher risk actually starts at age 45. So all Black men are at higher risk. So we'll be starting at age 45. Anyone with a family history, first degree male relative, so that's father, brother, son. One has it, the other is more likely to get it as well. So those are kind of some of the important risk factors. And if someone has a history of prostate cancer at an even younger age, they can start at age 40. So you'll sometimes see that guidance, like from the American Urologic Association, that you can actually establish a baseline PSA at age 40 and then monitor it from there.
See, that kind of information is not getting out. I don't see that either written or even talked about a lot, about the age so early, like 40, and I call it early.
Yeah.
Because it used to be that you had men started being concerned about it like 55 or something like that.
Yeah, right? much older, right. Yeah. And that's what I often hear, that especially someone with a strong family history, they've had multiple family members, first degree members at a young age, and they're also not. So I'm always glad when a patient asks me, and that prompts me. It may often be the spouse or the wife or somebody that's in the room and say, hey, we have kids, when should they start being screened? Things like that, that they want to know, and make sure that the family is educated on those risk factors. But I think for prostate cancer, it's a little bit controversial, or not the current screening guidelines, but there was this era between around 2013 to 2018 where the guidelines changed in the U.S. and actually just recommended against screening, and that got a lot of bad sort of attention and press and concern that it was actually sort of confusing patients, and patients that were at higher risk now weren't being screened. And that's actually what the data shows, that those were sort of more vulnerable and didn't have as much insurance or access to care or things like that are the ones who suddenly weren't getting any PSA tests. And people that actually maybe didn't need it, were much lower risk, still continued to get PSA screening. And we started to see patients diagnosed at more advanced stages. And then in 2018, the task force reversed that recommendation. And there was a lot of controversy actually also because when that first guidance came out, they acknowledged that Black men were not in the studies that they used to base that guidance on, the sort of major trials. One major one that was out of Scandinavia, really didn't include Black men in the United States or, Black men in general. So I think, yeah,
Scandinavian doesn't have too many.
yeah. So I think that history, kind of made things a little bit harder where we're sort of trying to catch back up now to like talk about screening. Whereas for other cancers, I say for women, I think we've done a good job where we emphasize things for like the pap smear and risk for HPV related cancers, and cervical cancer and gynecologic, screenings, breast cancer. We've tried to remove sort of the stigmas and the taboos around that. For men, we're very much behind in eliminating those things and having frank, open, candid conversations like this are the importance and not shying away from it so that somewhat normalizes it.
You know what happened, Doc, that sometimes we, and this is one of the pitfalls, I guess, that especially young Black men are having when they go get a physical. If they don't tell the doctor to include or tell the analyst to include in the blood test the PSA number, they won't do it.
Mm-hmm. Mm-hmm.
Okay, they'll just go and get a regular blood test telling you about all the other factors in your body based on your blood, but the PSA won't be included.
Yeah,
unless you ask them.
Exactly. Yeah, and I think that's why it's important to ask. I think always, you go in if the doctor says we're going to order some blood work or something. You say, what are we ordering? What are we looking for? Right. This is a bigger conversation, even just beyond prostate cancer. What are we checking for? And then just kind of explain, because most of the time, again, when I'm talking to people that say, well, I thought that was being checked for, they don't really sort of understand that. Sir, you have to be really specific with the blood tests and things you order. They're only going to pick up what you're looking for. You haven't ordered that test, it's not going to be examined. And so asking, what are we screening for? What types of cancer are you looking for? There's a big problem with like colorectal cancer and colorectal screening and being diagnosed at early age. We see all the famous Black celebrities at this point who've had colorectal cancer and disease from colorectal cancer at younger ages, and the guidelines shifted from age 50 to age 45, and it may go down even further in future years. But for now, it's important. And if somebody doesn't want to get like a colonoscopy, which is the usual test for colorectal screening, there are other types of screening. There's different test kits, something like Cologuard. There's virtual colonoscopy where you can, kind of swallow a capsule and it's looking. There's CT scan, CT colonography. So there's various forms. And a lot of times people, I think, are sort of shying away or afraid to kind of ask the physician, ask the provider, and have that conversation and exchange, again, around what are we screening for? What are the testing options? Just because one is recommended, say, are there any alternatives? Sort of simple questions like that might prompt and get more information. And certainly I'm not putting it on the patient. Providers need to do that too. But these are the things I think that the patients can ask. My experience of it, I encourage my family members, do these types of things, because we know, like, if you don't ask, it's often not going to come up. It may not even be it's not a negative intention. It's just that it didn't come up. But if we all have to kind of be our own advocates in that way.
Okay, Doc. So I'm going to hit you with this as we are coming to a close.
Yeah.
The diet implications.
Okay. Yeah.
So is there anything that's proven that could help to prevent the impact on the prostate, or give you prostate health, so to speak? What kind of foods are talked about?
Yes.
Or recommended?
Yeah. So I think that the best advice that we give, well, let me say this. We know that the kind of classic historical American diet, which is high in red meat, saturated fat, dairy, sort of whole fat dairy, things like that, has led to high rates of certain types of cancer. It's associated with high rates of certain types of cancer in this country, like prostate cancer in men, breast cancer in women. And for prostate cancer, I think over time we've got that messaging that we shouldn't be eating a lot of red meat, and animal products like that, and that actually a plant-based diet or incorporating more of a plant-based diet can be protective, can help to reduce the risk of getting prostate cancer or having recurrence prostate cancer. The good news, what I was pleased to learn, as I think others will be too, is that it's not all or none. We really like our meat at the end of the day, but so if you can still reduce, every little bit's going to help. So
Right.
like the guidance that we give, in our clinic is, having like red meat not more than twice a month, right? So if one guy says, well, I have it every day, well, try to make it twice a week, slowly try to make changes and implement and
Right.
get to that point can be helpful. But it's the Mediterranean diet. That's what I wanted to say earlier, that people, that is sort of that buzzword that comes up, that is associated with lower rates of prostate cancer. So it's little red meat. It's having more like fish or lean meats. Tomato is kind of like a healthy prostate healthy food. Cruciferous vegetables like broccoli, kale, collard greens, things like that can be protective. Foods with lycopene like watermelon, selenium is another kind of mineral that can be helpful.
Right.
There's a couple resources. I like the Prostate Cancer Foundation website, pcf.org. They're the largest philanthropic group in the world, actually raising money for prostate cancer research. So pcf.org. They have a lot of good patient-friendly information that's evidence-based, because it's hard to find, good, reliable. What is a reliable source of information on the internet when you're Dr. Googling out there? That can be a good source of information. They have free cookbooks, they have recipes, they have a newsletter where they send out different recipes and things like that. I see it in the chat, they're talking about exercise too. So another sort of part of that equation, which is important, is not just the diet, but it's also the exercise. There are increasingly more studies showing that higher levels of exercise are associated with lowering your prostate cancer risk. And even after your treatments, lowering your risk of recurrence. So we talk about upping the levels of exercise. There was one study, for example, showed that 150 minutes a week, we used to say, I think 90 minutes a week, 30 minutes 3 times a week. But if the person actually did 150 minutes, it was more like 30 minutes 5 times a week, or if they like to do, long hikes on the weekend. But getting higher levels of exercise actually does lower. And all of this is going to translate to lower reducing the risk of other things, cardiovascular events. I said cardiovascular disease still number 1 killer in the U.S.
Absolutely, yeah.
Cardiovascular disease still number 1. So all of this is going to also have benefits for that as well.
As you see in our chat over there, it's coming from Reverend Brown. Stephen Brown asked, how do Black men know what to ask their doctor to screen for?
Yeah. I mean, I think at starting by the age of 40, definitely by age 45, they should be asking if they're being screened for prostate cancer, or just say, I want to be screened. Should I be screened? Again, this is all dependent on family, if there's a strong family history or not, especially family history at a young age, that may need to be sooner. Excuse me. But, pretty much by the age of 50, there's definitely other common cancers. I mentioned colorectal cancer at the age of 45. Lung cancer is really important if their person has a history of smoking, or more than 20-pack year history of smoking. There's a what's called a low dose CT scan that can be done on an annual basis that can pick up, to try to pick up lung cancer. That's also very much underutilized. I know the American College of Radiology had a campaign really around that to try to increase, from a health equity standpoint, increase lung cancer screening in diverse, kind of underserved populations. So I think the key is asking your physician really, what cancers are being screened for, or is there anything that we should be screening for? And just kind of prompting them. It lets them know also that I want to be on top of this. I don't want to do less. I want to be ahead of this also.
I keep saying that we're running out of time. We certainly are. But it's just one key question here. Now, historically, when men, especially let's say 50 years ago, men all of a sudden come up with a type of cancer, maybe in the lung or bladder or something like that, or bone cancer. The knowledge about prostate was not that widely known then during that time, right? 50 years ago, right?
Okay.
Could it have metastasized out of the prostate without them knowing? And then all of a sudden, because if a non-smoker gets lung cancer, yeah, could that be attributed to metastasized prostate?
No, I got you. So usually, whatever that, so if we're picking up something in another area, say the bladder or the lung, and we do a biopsy, when we analyze and look at those cells, we're looking, what is the cell of origin, right? Because sometimes you might pick up a lung nodule on a CAT scan, they do a biopsy, and actually the cells show that it's a cancer from the colon.
Oh,
those are cells that spread, and then they go and do a colonoscopy and pick up the original. So the analysis that the pathologist does is really trying to tell us what type of cancer that is, where, and helping with, is it from that original organ or is it from somewhere else?
Oh, okay. Yeah. Well, okay, Doc. I've had my education for today, and it has been very educational. We've got a number of people who are really looking at this program, but we have 3 venues of dispersing it. We've got Facebook, we've got our website, and YouTube, and only the one on Facebook would allow you to type in comments, as you see on the side there. Okay, so we have a number of people who I'm sure, based on the ones that have stopped me on the street before this broadcast, they're listening. So I'm glad to know that. Good. And if you Doc, you're welcome at any time. And thank you so much for joining this discussion. And you're welcome at any time. Anytime you think it's pertinent for this kind of information to be conveyed, please let's keep in touch on that.
Thank you. Okay. Absolutely. It's great to be here, and I'm happy to come back anytime and chat more. There's always so much to talk about. So.
Oh, absolutely. and look, you guys are making the advancements and you're doing all the research. You got to keep us involved, okay?
Exactly.
Right. Okay. So thanks so much, and until next time, Godspeed.
Sure. Thank you so much.
Okay.
Thank you for watching the World Community. Thank you for watching the World Community Magazine's Hour of Power Live on Facebook.